Good evening, Endometriosis Summit crowd. I actually think we're on my Facebook page. So Dr. Vidali, if you want to jump on and share it to the Endometriosis Summit page, that would be awesome. Welcome to our first of, I believe, 12 Endometriosis Summit lives, where we come to you every Monday night talking about topics in endometriosis. Tonight, we are doing abdominal wall endometriosis with some amazing panelists. Please welcome, we're gonna go, Dr. Chung suggested alphabetical order. So please welcome Dr. Maurice Chung. Dr. Chung, can you introduce yourself to everybody?
Hi, everybody. I'm Maurice Chung. I'm from Canton, Ohio. And Mercy Medical Center by February 1st is becoming Cleveland Medical Center in Canton. And I'm a urogynecologist. Then my main focus is the chronic pelvic pain, of course, endometriosis and minimally invasive surgery is also my focus and interest. So I've been dealing with this for the last 30 years. And so that's simple. That's me. I'm here.
Dr. Chung is very modest. Dr. Chung is the person who coined the term the evil twins of pelvic pain, who founded the connection between interstitial cystitis and endometriosis. So we are extremely honored to have you here, and I am honored to have you as my personal friend. Great. Moving alphabetically, please welcome Dr. Fogelson. Dr. Fogelson, please introduce yourself.
Hi, I'm Nick Fogelson. I have a private practice in Portland, Oregon called Northwest Endometriosis and Pelvic Surgery. I got into pelvic pain and endometriosis care kind of casually 15 years ago, and then very seriously maybe about a decade ago. And in the last 5 or 6 years, it's really all I do. And I do a lot of really complicated endometriosis work with bowel and bladder and all kinds of endometriosis stuff. And then I've recently become very interested in neurologic involvement in the pelvis, and studied with Mark Possover in Switzerland for neuropelviology, and that's been very, very fascinating as well. And I really enjoy complex, unusual cases, and really try to dig into them and see what I can do to help. So Sallie, thanks for joining me, and we'll talk about abdominal wall endo on this one.
Welcome, Dr. Fogelson, and please welcome direct from the OR, Dr. Raccuia. Dr. Raccuia, can you introduce yourself to everybody? You're maybe a little less well-known than everybody else here.
Well, I'm a general surgeon who actually specializes in liver, pancreas. Trained in France for a few years, and I basically support Dr. Vidali with his cases in terms of whatever any technical expertise he needs, and basically that's it. So my entry to endometriosis really has been vicariously through Dr. Vidali, who has made this incredible practice with multiple surgeries, and I've been able to participate with every single one of his cases, and a very, very interesting path we've taken over the years with this, and learned a lot. So I have experience from everywhere from the diaphragm down to the pelvis in my previous experience, so with a lot of cancer work. And this is really like a cancer without being a cancer, and I'm intrigued by it.
Awesome. Okay, and please welcome, we're all seeing her for the first time, Dr. Megan Wasson. Dr. Wasson, can you introduce yourself to everybody?
Good evening, Sallie, and good evening, everyone from across the country, maybe across the world. I am Megan Wasson. I am at Mayo Clinic in Arizona, where I am the chair of the Department of Gynecology. I am a minimally invasive surgeon, so trained to really specialize in pelvic pain and endometriosis, but I have had unique training that I was trained by GYN oncologists, which has really prepared me to tackle endometriosis everywhere. So similar to the other experts on this panel, I can tackle diaphragm endo, bowel endo, bladder endo, wherever it is, I will take care of it, including the abdominal wall. So I'm very much looking forward to chatting with everyone tonight.
And we have, of course, my partner in crime for the Endometriosis Summit, Dr. Andrea Vidali. Hi, good morning, good evening, Dr. Vidali. You're
He's muted.
I muted myself. Sorry, it feels like morning. This day went so quickly, but hello, everybody. Sallie and I have been at the Endometriosis Summit now for, what is this, our third year? Our
Yeah.
third year. And, I'm very excited to be part of it. And I think what I bring to the table is a little bit extra experience in the world of fertility, as well as immunology, more specifically reproductive immunology. And I'm very excited today to be part of this group. Thank you, Sallie.
awesome. So let's get right to it. Let's talk about abdominal wall endometriosis. You can, because we have cameras on. How many of our doctors out there see a couple cases of abdominal wall endometriosis a year? Hands up, right? We're all seeing that. And I'd love to know, Dr. Wasson, how do you diagnose abdominal wall endometriosis?
So a lot of it is based on symptoms, which is honestly where endometriosis diagnosis starts for wherever the location is. But abdominal wall endometriosis, a lot of times there will be very specific cyclical pain in the abdominal wall that kind of clues you in that there might be an issue going on. And then the next step to really help guide as to whether or not there is an abdominal wall endometrioma is imaging. Here at Mayo Clinic, I'm very fortunate that I have amazing radiologists in both ultrasound and MRI that can help evaluate for the abdominal wall endometriomas. And once they are able to do the imaging, give me an idea of what they think is going on. If we're still on the fence, once in a while, I will do a biopsy, but very frequently we don't have to do that. You just know based on the imaging that it's an abdominal wall endometrioma and move forward with treatment.
And so, right before everybody came on and we went live, Dr. Fogelson and Dr. Chung were having a conversation that not all that ails people when it comes to cyclical pain is endometriosis. So Dr. Chung, if somebody came with very specific abdominal wall pain to you, how would you work them up that's maybe a little different from how a surgeon would work them? I mean, you are a surgeon, but what would you look at being somebody who also embraces multiple causes of pain that could be causing their abdominal wall pain?
Well, depends on whether the pain is actually located above the umbilicus or below the umbilicus. And many pain that below the umbilicus is actually a refer pain from the pelvic neuroanatomy. And the pudendal nerve do refer the pain to the right and left lower quadrant. And the bladder, it could refer to the suprapubic. So, the things that clue me in, or actually give me a little bit more suspicious, I don't want to give a whole discussion because it takes forever, is that, first of all, you have to know, is this a refer pain? And the most common refer pain to the left and right lower quadrant is pudendal nerve in the deep pelvis. And so if you can exclude it, then you got to question whether the patient have any prior surgery, C-section, because many times the abdominal wall pain could be the neuropathology of the ilioinguinal nerve or the genitofemoral nerve or iliohypogastric nerve, or sometimes could well be a trigger point pain. So imaging, I would get it, but I don't want to pay the radiologist or have the patient pay like $1,200 just to get an MRI. If something is painful, if it's a nerve pain, you can localize in one spot. The first thing I do is make sure that most of the time it's not just the abdominal wall pain. It is so infrequent. Because anytime with pain, there's always a pelvic component that goes along with it, or maybe the bladder pain that goes along with it. So of course I have to exclude that first. If the pain is still there, then I may give an injection just to see whether I can knock it out. And then at the very end is the imaging. Imaging may not tell me anything, sometimes tell me a nodule or some dense tissues. Regardless, I was just gonna take it out if that's the case. But then that's the issue. Taking it out involves a lot. Sometimes you got to involve the surgeon, because if that is a big mass, then you're going to end up losing a lot of muscle and fascia, and you may need a graft. So that's my approach. I'm going to focus on the pelvis. I'm still a urogynecologist. Make sure that it's not a refer pain. Then I go up a little bit higher. Then I give the injection. If it knock it out, it doesn't come back, that's good. Whether it's cyclic or not, it doesn't really matter. It's whether the pain is gone or not. So then it will be the surgery at the end.
And Dr. Fogelson, do you have anything to add about evaluating for abdominal wall endometriosis?
Yeah, I agree with definitely some of what Dr. Chung says, maybe a slightly different perspective. I think that abdominal wall endometriosis is a really completely different condition than quote pelvic endometriosis, and they have the same name, but they may as well be two completely different diseases with unrelated names. Abdominal wall endometriosis is almost always an implant of endometriosis that got put there in some previous event. That could have been a cesarean section, it could have been a laparoscopy, it could have been a perforation of the uterus during a D&C where they stuck up in the abdominal wall. I don't think, I mean, I've done like 40 or 50 abdominal wall endometriosis surgeries. I don't think one of them happened you can't tell where it happened in the past. Some of them were from morcellated uteruses, when people done uncontained morcellation for fibroids and they left a chunk of uterus in there. I had one of those. So I think that there's a very characteristic diagnosis, and just like all endometriosis, a lot of surgeons or physicians miss it. As I was told by one of my attendings, the eyes don't see what the mind don't know. And if people don't really know about abdominal wall endometriosis, they'll often not make the diagnosis. But there'll be a mass. Usually the patient will tell you that there is a mass in their abdomen. They can feel it. It gets big during their menstrual cycle. It becomes exquisitely painful during their menstrual cycle. And if the patient is thin enough and the mass is above the fascia, you can reliably feel it, especially if you feel it during the menstrual cycle. The one trick can be that if it's beneath the fascia, which usually is in cases where it was implanted during a laparoscopy instead of during a C-section, if it's underneath the fascia, you may not feel it because the fascia, you're feeling the fascia on top of it. And in either case, if I have that suspicion at all, I'll generally get imaging, and I think MRI is useful. CAT scan can give you the same information and maybe cheaper, but and then using that imaging, you make surgical planning. And I'm generally not going to do anything conservative, because in my experience, if you truly have abdominal wall endometriosis, nothing's going to work other than taking it out. This is not pelvic endometriosis that recurs. If you get good margins and you thoroughly remove the lesion, I think you have a 100% cure rate. So I'm pretty aggressive about just taking it out surgically.
Right, and I think when Dr. Raccuia talks about how his past is as a cancer surgeon, that abdominal wall endometriosis presents much the same way, in that you have to really get a clear margin on it.
Absolutely. Well, I mean, I've done a lot of redos. I mean, I'd say half of my cases have been operated on before, and it's almost always that they didn't go through the fascia. They cut out above the fascia, and they said, well, I don't want to take out the fascia and cause a hernia, but it doesn't work because the disease is almost always invasive into the fascia, at least somewhat. And so people that don't do a lot of these cases are often not aggressive enough, and then the disease either recurs or it never got better in the first place.
Go ahead, Dr. Chung.
Well, it's easy to say if there is a thin patient and the mass is big, but many times you have an average American, and then they feel that there's a spot in the abdomen that hurts. And so that's the catch. So if you can feel it, you can feel a nodule or mass, yes, it's very easy to say, okay, we can cut it out. But those are the one that is so obvious. It's the one that, okay, I have this part that it hurts, and it may be a little less than the size of a peanut. And those are the cases that, is it the abdominal wall endometriosis? You think the CAT scan is going to tell us? So that's where I feel that I'm a very conservative in terms of surgery. It's not that I don't do it, but in this case, Sometimes you have no clue whether it is or it's not. And sometimes it could well be a neuroma when you go and take out a chunk of scar tissues. And that happened infrequently.
Yeah, we're certainly not going to operate on someone without a clear indication that there's
Right.
something to do. I mean, we're not going to go cutting a hole looking for something. I mean, you're going to know it's there. I mean, high frequency ultrasound is actually very useful. I have a vascular ultrasound in my office because I use it for doing ultrasound guided blocks. And you can see abdominal endometriosis very well on a linear probe high frequency ultrasound. So a lot of times I don't even get cross-sectional imaging because the ultrasound is very accurate and we can do it just in the office.
So was there a size that will give you like how big is the size that we'll be able to pick it up?
Yeah, and it'll also show you disease underneath the fascia. And I've increasingly seen cases where, I don't want to monopolize the time because I want to hear from other people, but I've increasingly seen cases where you had an implant at laparoscopy and it ends up underneath the fascia, and people have operated on them and found nothing, and they go, oh, there's nothing there. And it's like, no, it's underneath the fascia. And if you don't see it on cross-sectional imaging or MRI or ultrasound, you're just never going to find it. And the only way to remove it is to laparoscopy. You come from underneath, and I can show you guys some pictures of that if you're interested.
So that's a good transition point. Dr. Fogelson and Dr. Wasson have some pictures of what's going on. We'll start with Dr. Fogelson since he transitioned, but do you want to show us some of your pictures with a share screen?
Yeah, absolutely. I'll show you a few different cases. Let me try to share.
The setting is on. Oh, there we go.
Is it working?
Trigger warning for people. There are surgical images, right? You know, so.
Yeah,
right. Let me remove all the porn. No, I'm just kidding. So this is a video of one of our surgeries. So this, I'm going to turn the volume off. So this is actually an abdominal wall lesion. I can't remember if this has a imaging. It doesn't, but so this is a lesion that is underneath the fascia that's removed laparoscopically. And this particular one was actually, I believe it was from a not umbilical, but a suprapubic port in a previous laparoscopy site, where someone had probably left a bit of something on the port. And basically we're just using traditional laparoscopic instruments. And I have the patient in a steep Trendelenburg with their head down. And then we're basically just cutting away at some of this tissue. And I don't want to take too long, but here's the healthy muscle. This red is the healthy muscle. And over here, you're seeing fibrotic endometriosis here. And so by the time we're done, we have completely removed this lesion. And here we're kind of cutting through some muscle. But, you know, sometimes this is required. And I think these are the cases that get missed a lot because people come from above and they don't find the lesion, and it's because it's not above. This is the fascia. This white stuff is the fascia. So if you were trying to cut above, you would never see this because it's underneath. There you see the brown released tissue from endometriosis. And so this is kind of a laparoscopic type of case. And then I'll show you other cases. These are from some blog posts that I did in the past. So this is an example of cross-sectional imaging that shows abdominal endometriosis. It's always easy to see because it says AWE with an arrow, and that'll tell you that it's abdominal endometriosis. Right. No, I marked that. But so this is the abdominal wall endometriosis here. Here's another one. This is a different case, a little bit more subtle, but you shouldn't see, in a little bit of a heavier patient, you see there's more fat. You really shouldn't see this kind of density because this is the same density as muscle. Basically, this tissue is catching as many blocking as many x-rays as the muscle is, and fat should let x-rays through very nicely as you see this black stuff, whereas this tissue is blocking x-rays, so you know that it's denser than the fat. And basically, when you come through, when you remove it, you get a lesion that looks like this. And I say that it's not the same disease as pelvic endometriosis because I have never seen a lesion that looks like this from pelvic endometriosis. It has a well-circumscribed margin. It almost has a capsule, and it's very, very dense. And you just don't see that in pelvic endometriosis. Here's another one. You talked about mesh, that sometimes you have to put mesh. So this is a big endometrioma that's in this patient's abdominal wall here. She had a bunch of different people that saw her and didn't seem to know what this was, which was unfortunate. And actually somebody biopsied it and said, oh, it's endometriosis. You don't have to do anything about it because they were worried it was a sarcoma. So sometimes what happens is surgeons will see the patient, they're worried it's a sarcoma, they biopsy it, they say it's not cancer, and then they drop it. They say it doesn't matter anymore, which is ridiculous. So here's this lesion, and this particular one required a reconstruction. You can see we're making an incision, removing a pretty big piece of tissue here. This is a fairly large piece of tissue that's coming out. And again, this is actually her bladder, because we've come through the fascia. This is her bladder. There's the lesion coming out, pretty large. This is a 5 centimeters across lesion. And now we're left with a hole in the fascia. This is actually the top of her bladder, so the fascia is gone. And now we're taking a piece of mesh and we're attaching it to Cooper's ligament, which is sort of the top of the pubic bone, and then pulling that mesh up underneath the rectus muscle. And then we're pulling that, suturing it over and closing it. And with a hole that big, you always have the option of just closing it without a mesh, but you're going to end up with a hernia one day. So we'd rather just fix it up front if it seems like it's that big. And you can see the final incision is really not that large, and it's contained. Her previous cesarean scar was that big, and so that the surgical scar from what we did was maybe 3/4 of the cesarean scar, but it can be even smaller if the lesion is smaller. We have other ones too, but they all look about like that. And I'd love to see Megan's pictures also, Dr. Wasson.
Absolutely. Let me switch over. Oh,
I'm going to stop my screen share. There we go.
perfect. Thanks, Nick. So let me switch over and share this. Okay. So, few different pictures.
Ooh,
This one
that's
is
a bad one.
Yeah, this one's a pretty impressive abdominal wall endometrioma. So this is an MRI, and this was a C-section scar. So it's about 6 centimeters across. You can see all of this is abnormal in this area. And so I use a lot of intraoperative radiology as well to help make sure that I'm getting clear margins. And I'm going to show some pictures of that in a couple other cases. One of the key things that I find so important about the imaging ahead of time is when you get into surgery, a lot of times intraperitoneal, which is where we're looking right now, things look 100% normal. So this is that patient with the huge abdominal wall endometrioma, but to look at her anterior abdominal wall, which is right here, it looks pretty normal. So you can easily miss these if you don't know that you need to be looking. And similar to what Dr. Fogelson was mentioning earlier, this is a different beast than pelvic endometriosis, because to look at her pelvis, she has a little bit of endometriosis down here, but not significant. This isn't a stage 4 endometriosis. This is just some superficial disease that I removed as well. But really the bulk of her symptoms were coming from the abdominal wall endometrioma that was resulting from her prior C-section.
Do you scope all your patients, Dr. Wasson?
For abdominal wall endometriomas?
Yeah, I mean, I don't. I mean, if they've had 3 children before and had a C-section and then have an abdominal wall mass, I don't even think they have endometriosis. I don't necessarily even do a laparoscopy.
So
Maybe I should.
Could I say something too?
Yes, go ahead, Dr. Raccuia.
I'm sorry, just a couple of things, if you don't mind. Again, I'm not a gynecologist, so I come from a whole different area. Just want to make a few things. First of all, for me, imaging is it's 100,000% you need imaging because you have to plan what you're going to do. The other thing, in terms of this type of endometriosis, in our experience, it's very rare. I would say it's probably 0.5 to 0.7% of our patients, and we've done about 1,000 patients so far. We've had 7 patients. Most of them have had, if not all of them, from my notes here, I'm looking at my data, all had pelvic endometriosis at the same time, at least in our experience. So we approach these with imaging. Like I said, I prefer a CT scan with IV contrast to plan the surgery, number one. Number two, in terms of getting a margin, it's very important. And in terms of the ability the need for mesh is, in these cases, I would say about 70% of those patients, at least in my experience, as a general surgeon, we use mesh, we use biologics, but the whole disease, I want to say the whole process seems to be, at least in our experience, with lesions that were pretty significant in terms of either you add the symptoms together with the mass, either the location or the size. And the location can present some difficult technical problems as far as I'm concerned, especially the fan and steel incisions where usually they're lateralized. It's not usually in the center. And some of these patients are obese. On top of that, they need mesh, and it becomes, these are, in my experience so far, these were not little operations in terms of, cherry picking. The dilemma that I've had with Dr. Vidali is, how wide do we go? We do like to get margins, but I think one has to also respect the tissue. And then at the same time, one has to remember that even though the incidence of clear cell cancers in these patients is extremely small, when you're dealing with a young patient, you want to make sure that you have a margin that's, that's not going to recur in terms of that. But overall, I agree with everybody in terms of the approach. I guess the only thing that I do a little differently, from a technical standpoint, I really like to be able to look at the whole abdominal cavity. I look at all the musculature, and I decide preoperatively, how large the operation is going to be. So that's basically my overall input. Oh, and one last thing, there's some really interesting articles. There was one article in Korea, 38 patients, 76% of the patients had subfascial and or muscular involvement. So it's not, a cherry pick for the most part.
Yeah, and so
yeah.
Along those lines, Nick, to your question of, do I scope everyone? I try to approach these abdominal wall endometriomas as minimally invasively as possible. So as long as it's not completely above the level of the fascia, I will approach it from the peritoneal cavity, remove the endometrioma, and then if we need a mesh placement, I do have my general surgery team come in and place that mesh through the laparoscope. That way we keep all of those incisions nice and small, and the patients tend to go home the same day.
Dr. Chung, did you have something to add?
I could not agree with Dr. Raccuia, because 60-70% of those need a graft because the size, and to get an imaging pre-op is just to see the extent. And I don't know whether I can share the screen, but I have a couple of gross picture.
Well, why don't we see Dr. Wasson's slides, because she was presenting and then we got sidetracked.
All right, good, keep going.
Let's let Dr. Wasson finish and then you can share.
Yeah.
So this is going through that abdominal wall endometrioma, and you can see very similar to what Dr. Fogelson showed, nice normal muscle right here. And then here's a very nice shot of coming through endometriosis tissue. So you see that chocolate fluid, that's endometriosis. And so this abdominal wall endometrioma extended all the way down around the pubic bone. And so this is the pubic bone right here, just reinforcing what everyone is saying, that you have to be aggressive to get the entirety of the endometrioma out. I needed to shave along her pubic bone to get the entire lesion removed, and then do an abdominal wall graft that we then covered with peritoneum. So this is what that patient, her abdominal cavity looked like when we were done. Another lesion not as significant is shown here. Again, I prefer MRI just because my radiologists are able to really hone in on the endometriosis. So an abdominal wall endometrioma outlined in that yellow. And then I have my ultrasound team come in during surgery. They mark where the endometrioma is for me. That way I can ensure I'm getting clear margins, removing all of the tissue, because like I said, a lot of times you can't see it when you're going from the peritoneal cavity out.
Yeah, so I think one of the issues, Dr. Wasson, that we have with the imaging, we're a patient and practitioner meeting. So we always present the patient side of this. And one thing that I remember from the Endometriosis Summit 2020 was how much frustration and anger there were from the patients that were speaking up at our microphones, that radiologists and imaging had failed to recognize so much of what was endometriosis. And so you come from a clinic where it's like amazing radiologists, and they work with you and they know you're there. And I think a lot of our, and we have comments like crazy off of Facebook, is that people miss it and they go to their regular doctor, and their doctor may order a CAT scan. And we know that the CAT scan read by the local radiologist, the goal is to make sure they're not dying of something, and they miss it. They never, very few patients will have amazing images read properly like this one. What do we do about those patients?
I 100% agree with you, Sallie. And it's not just the radiologist, it's the gynecologist. And so, from a professional side of things, we are working extremely hard to educate our colleagues to make sure that they know how to look for this stuff, not necessarily know how to treat it, but just know that it exists, and to say, okay, yes, I don't know how to treat it, but I can get you to someone who does. From the patient side of things, I love when the patients are their own advocates. So attending the Endometriosis Summit, educating yourself, knowing for yourself what these symptoms are and what potentially is going on is the first step. And never, ever, ever be afraid to say to whoever you're seeing, I think I have endometriosis. I think I have this going on. Can you help me? And if the answer is no, find someone who can. Especially right now with COVID, one of the advantages, a lot of us are doing telemedicine. So it doesn't matter where you are, you can reach people from across the country to get the help that you need.
Yeah, and on imaging, I mean, I get all my, if I order an MRI, I don't care what the radiologist says. I mean, I'm looking at the pictures myself. I don't, on anything, pelvic, bowel endometriosis or whatever, like I fully expect that I'm going to be better at looking at a endometriosis cross-sectional imaging than the radiologist is, except for just a few radiologists that I work with a lot. And you're right. I mean, people will order imaging looking for the random thing that's causing the pain, and that's a very bad way to do it. I mean, you really should be ordering imaging to confirm what you already suspect, not looking like blindly, because yeah, radiologists are looking for the stuff in the abdomen. They often don't see the thing in the abdominal wall. And it's sort of the classic thing is, what's the hardest lesion to see on any imaging study? And the answer is the second lesion, because they see one thing and they thought that was it and they stopped looking. So I've seen tons of cases that people missed. And in fact, I had one patient that got operated on by an oncologist for first they morcellated a uterus, then they went back and took out a mass laparoscopically, then they went back and took out abdominal endometriosis through the skin above, and then they said the patient's crazy. And then she came to see me, and the MRI clearly showed the disease, but it was under the fascia. So it just doesn't, and that MRI had been read as negative. So it just really requires people to really look at it.
One thing about imaging I can add to you, what Dr. Fogelson said. Remember something about surgery, we forget that we're better than the radiologists. And the reason is that radiologists are only exposed to two-dimensional views with the black and white most of the time. We three-dimensionalize our views, and the better we get at surgery, the better we are at reading these x-rays. So 1,000%, I can tell you this, a dictum from having operated on many livers with breast cancer. The French had a saying, the image saw 3, you found 4, but there were really 5.
Great.
Probably sounds good in French.
Yeah.
Great. Yeah. Great. Dr. Wasson, do you want to continue?
Yeah, so this is that smaller abdominal wall endometrioma. And again, inside looking in the belly, this is the uterus right here. And it just looks scarred to the abdominal wall. So to know to look for that endometrioma isn't necessarily that easy. But what I do is have the radiologist place needles, and I'll show that in the next slide. But here you can again see the normal tissue as we're peeling it down, and then that endometrioma, which is all of the diseased, abnormal looking tissue right there. But I have the radiologist come in, and under ultrasound, they place these needles for me that I can move in and out during the surgery, and it really marks where the margins are. So if I'm not sure where I need to go, they push the needle in from the abdominal wall. That's where I begin my dissection. And then I also know where I finish my dissection. And so at the very end, I push all of the border needles in, showing myself, yes, I got outside those borders and I have the entirety of the abdominal wall endometrioma removed. And so this is what the abdominal wall looks like when I'm done. And then to the point of the fascia, that's where the imaging I still think is extremely important, because it will tell you, is it subfascial, is it involving the fascia, or is it superfascial? So where exactly in that abdominal wall is it, and how deep are you going to have to go?
And it's just a side comment, that case that you just showed never would have happened, in my opinion, if the surgeon had closed the peritoneum at the time of the cesarean section. And we're we're told this ridiculous thing in general training that it doesn't matter if you close the peritoneum at the time of closing a cesarean section. And the only data that's ever shown that to be true has to do with how difficult the next cesarean section is. It has nothing to do with whether or not the anatomy is actually normal later. And, you know, you leave a sloppily open hysterotomy with an open abdominal wall, and that's what happens sometimes. And it's unfortunately just because of, in my opinion, kind of inadequate surgical technique.
And to add to that, Dr. Fogelson, we have a technique of closure in general surgery called the mass closure. And basically, it's been described, well described in literature. What it is, you know, taking the whole anterior fascia, muscle, and peritoneum, and they're big bites, but in terms of you know, preventing a hernia, probably that's the best thing to do. And that's in general surgery, we're talking about hernias, not about endometriosis. So the point is even more poignant in what you're saying. But you know, doing a mass closure would probably prevent a lot of this recurrence.
So along those lines, this is the last case that I want to share, but this abdominal wall endometrioma is actually a little bit higher, far away from the uterus, but it was still caused from a C-section. And so this is intraperitoneal. You can see the uterus all the way down here. Yes, she has some adhesions between the bladder and her uterus, but the abdominal wall endometrioma is clear up here, very superior to where that C-section incision was. And so again, those needles, I couldn't do these surgeries without them to help me localize. And so removing that endometrioma, beautiful, healthy muscle. We see the abnormal blue, black, brown coloring from the endometrioma that we're able to peel it away. And then at the end, we see nothing but healthy, normal tissue. So these cases, in my opinion, can be made very easy or very challenging, depending on the imaging support that you have.
Excellent. I wonder, Dr. Vidali, for patients who undergo abdominal wall endometriosis surgery, but then want to carry after, how does it affect fertility, both the surgery itself, but also putting a mesh in? Does that change the immune response regarding pregnancy?
Well, I think it's an important consideration in the sense that, of course, if the patient requires another C-section, what are you going to do, right? And one can always cut through the mesh. It's a known fact. But you're setting yourself up for, you know, a huge problem. You know, from an purely inflammatory standpoint, the mesh should be considered relatively neutral, believe it or not. It just causes, you know, local fibrosis. Although I have to say, just what Joe just said earlier, is that we use biologics. We don't really use plastic meshes for these operations. I would like to say that these are quite complex operations, and I've seen at least 2 huge complications from these surgeries. One, which was not our patient, but she came to us afterwards, and she had a wound that was open for a solid 6 months with a wound vac. Okay, so because these are huge holes, and sometimes it's hard to close them, you know. So on one of our own patients, there was a wound infection, a patient, you know, that took quite a while to recover and close. And, you know, so I think we should not underestimate the complexity of these operations, especially when it's very deep and very wide. So these are not to be, they have to be taken seriously, these operations. That's what I think. Yeah.
I'd love to ask Dr. Raccuia, you guys use biologic mesh. So I used to do that, and I found that 2 concerns. One is that eventually it's going to be gone, and there may be a hernia risk, since you're not reinforcing a weak spot, you're literally trying to replace missing fascia. The other is that you get a seroma formation that seems pretty reliable, and you have to put drains in for some extended period of time. So what's your thoughts on that?
Number one, it is a mesh is a mesh. It's whether it's plastic or biologic, so it acts as a deterrent to hernias. Number 2, I think the addition.
But doesn't the biologic get eaten up? I mean, it doesn't stay forever.
If you, and I've used biologics now, specifically Stratus, for about, and there's techniques to it. And you're right about the drains, but there's techniques to it. I have maybe over 15, 16-year experience with this, doing a lot of abdominal wall reconstructions that are not, endometriosis. And I think the addition of a component separation with a lot of these operations is very utile, number one. Number two, in terms of addressing the idea about a biologic melting, what happens, and I've had this experience as well over 30 years of my career and about 15 with these biologics, when you have to go back, let's say you do an incisional hernia in a midline, you go back a year later, you can barely tell the difference what you think is fascia and biologic because it gets completely incorporated. There's these cones of things that get incorporated, and it's hard to distinguish, but it is a fascia. So the thing that you're addressing, I think a lot of people have thought these things, they melt, they go away. Number one, the seroma formation is 100%. And what I learned the hard way was you have to have a drain below the fascia and a drain above the fascia. So in other words, what I do is I close the defect for the most part, do component separation for the most part. And I think it could be an extensive component separation, a small component separation, but that's the key to hernia surgery in terms of when you're putting in a large mass. The second thing, if you have a biologic with a seroma, and again, I've learned this the hard way, it will not heal because the tissue doesn't granulate over the biologic like it does with other, plastic type meshes. So removing the drain, and usually I think my drains probably stay anywhere from 2 to 10 days, depending upon the drainage. But I will guarantee you the drain, as you pointed out, is probably as essential to the surgical technique. So and it is, a biologic is a hernia repair. And the other thing in terms of the repair itself, when it's an open repair, I do what I call a U-shaped stitch. It's multiple interrupted sutures, and they're probably, I would say, about 1.5 centimeters to 1 centimeter apart. So it's a very nice tight repair. I feel it, and then I component separate, and then I close the fascia completely over the mesh, and then place the drains below and under. But
so for the audience that doesn't understand the inside baseball, that there's a technique for actually partially cutting through the abdominal wall. The abdominal wall is like a layer of sandwiches, and if you're trying to make a sandwich bigger, you could cut the top piece of bread and then slide like this. And so now the thing that was this big now becomes this big because you've slit it. And that's what he's talking about in a component separation.
So you have to close the fascia.
I'm going to take
yeah.
One moment for everybody out there that's like, what is the Endometriosis Summit doing right now? So just like we're going to announce that we added a third day that's going to be entirely like this, where surgeons and physicians talk to other surgeons and physicians, but we allow not only surgeons and physicians to be there, but patients to watch it all. Because as Dr. Wasson just said, you have to learn how to advocate for yourself. So you kind of have to almost become your own doctor. So this is a perfect introduction to our new day of Endo Summit surgery. I wonder, and Dr. Raccuia and Dr. Vidali were talking about this just as we came on the air, but I wonder, what is the difference between primary abdominal wall endometriosis and something like iatrogenic or secondary abdominal wall endometriosis? And what do you think the incidence is of each? Dr. Vidali?
Well, you catch me a little off guard because I don't really know the numbers, but what I can tell you is it happens.
Yeah,
okay, Joe, please, sorry.
Joe might.
I want to say something though. I wanted to say it happens to the best of us. And I like to say that I thought because we're always extra careful whenever we extract samples to put them in a bag so you don't contaminate. But just recently, and it's the first one in 25 years, but I have to admit to it, I had a patient who called me who had surgery in the UK. And by the way, she had minimal endometriosis. This was like not one of those crazy cases where you take out a lot of disease. And she ended up with 2 implants in one on the umbilical port and one on the side port. And I can tell you that these were like tiniest piece of disease removed. So it happens even if you're extra careful. Of course, I thought that I was immune to this, but I don't think anybody's immune to this problem. Now that
But the other
happened to me.
question, Andrea, you know, David, I don't know if Redwine's right, but I mean, Dr. Redwine has surmised that the injury of the laparoscope going through there may have induced some metaplasia. I think I think he's wrong, but he has brought up that idea that maybe you didn't leave endometriosis in the abdominal wall, but it just actually transformed normal tissue that way.
Dr. Redwine, Dr. Redwine is our keynote this year. So perhaps log on March 7th and you could ask him, because it's going to be an open forum to talk to him.
Whether he's right or not, he'll tell you the answer.
He'll tell you exactly. We can't wait
to answer.
We're so excited.
To answer,
Joe, please, sorry.
Yeah, go on.
Joe,
To
please.
answer your question, it's interesting because, first of all, let's take the whole gambit of abdominal wall endometriosis. Extremely, extremely, extremely rare in face of the denominator patients with endometriosis. In our experience, it's 0.5%, which is pretty low. In the literature, depending upon the paper you read, it's anywhere from 0.2 to 12%, but you know, again, the cohorts are very small. The terms of primary, we call primary endometriosis, there's probably not more than a couple of dozen cases in the whole literature. We had one patient where she was menstruating through her belly button, but that's extremely, extremely rare. I would say the lion's share of the cases are iatrogenic, at least as described, and the lion's share are in the fan and steel incision. And believe it or not, people have kind of broken it down between umbilical area versus fan and steel. This is with incisions. And they found women that didn't have children, 75%, in one fairly large study from Pittsburgh, 65 patients had no children. They never had children, where 67% of the patients with the fan and steels, of course, were childbearing. Whether that's a statistic that makes a difference in terms of the realm of endometriosis, it's still a fact. So it's an extremely rare entity. And again, in our experience, it's no more than 0.5, 0.6% of all the cases that we have seen. And that's probably over 1,000 right now.
I think I agree with you. I think that the only primary cases I've ever seen were umbilical, where they just seem to have it for no apparent reason, and it's always been in the umbilicus.
Well, when you see primary like that, you should probably consider removing the urachus as well if you have a patent urachus. That's my opinion.
Can I ask a question to the doctors too? In terms, look, umbilical is a big issue, and I'll tell you for a lot of things. And we actually have some dilemma sometimes with this. How far we've done umbilectomies on patients, which at the end of the day, a young woman for the most part is not happy with. And then we've done, other types of surgeries where we try to preserve as much as we can, at least reconstruct the umbilicus. And we've had some pretty good results with that as well. But it really depends in our experience, how big the lesion is and how much of the umbilicus and subfascia is involved. But I have to say, I have done many umbilectomies in my life for other things, cancers and the whatnot, and you don't necessarily think twice about removing, the abdominal wall, skin, umbilicus, and everything. These patients, I think we have a little bit of a different dilemma in the sense, taking away the umbilicus sometimes is not a pretty sight. So, from a cosmetic standpoint, we really try at our best to reconstruct the umbilicus when possible. I like to hear what the other surgeons do.
Now the plastic surgeons, when they have to do the umbilectomy or however we pronounce that, they do recommend that instead of a reconstruction, or instead of that, they do either they do a tattoo on, or they do, because it's safer to keep the abdominal wall having its integrity. Do you all feel the same way?
I think it depends on the patient.
Wasson nodding, keep nodding.
So
Well-
go ahead, Dr. Chung.
No, I don't have much to add other than nowadays the patient, what patient wants is so much different than in the past. And cosmesis is important. And of course, whenever we counsel the patient, like, okay, you got this little umbilicus of a 18-year-old with so skinny as compared with somebody who weighed 250 pounds and there's a large lesion. I guess all these have to be considered. And I guess a lot of discussion has to happen. This is what I have to say.
And I would agree and echo that. I think the biggest thing that happens preoperatively is that counseling and the expectations with the patient that no, cosmesis may not be what you want it to be any longer, but my goal is to have this be the one and only surgery that you need for this. Instead of going back to the OR over and over and over again to keep slowly chipping away at the area, whether that's the umbilicus or pelvic anatomy, you really want the first surgery to be the best surgery. And if that involves removing the umbilicus, then that's what we have to do.
I couldn't agree more with Dr. Wasson. I mean, I think that every single failure of abdominal wall endometriosis surgery I've ever seen, which again, like half the cases I do are redos, they're all from some surgeon that tried to not do it enough. You know, they didn't remove enough tissue. I mean, and it's sort of obvious. You can even look at the op note and you look at what they did and you're like, well, that's not going to work, what they did. And I think you can, I've had a few cases where I scrubbed it in with plastic surgeons in these and we reconstructed the umbilicus. It looked pretty good. I mean, it didn't look perfect, but you know, and now it's not actually that hard. I've done it myself. I mean, you can, even if you go all the way through the fascia and you make like a $50 size hole in the fascia, that's small enough that you can probably primarily repair it. If not, you could put a little pull-up mesh under there and then bring the tissue together. And then you can do a number of the suturing techniques that kind of makes a little bit of a helical closure to the skin. And you end up with, you know, we got to remember umbilicuses all look different. It's not, there's not only one way that an umbilicus looks. I mean, some people have innies, some people have outies, some people have all kinds of stuff. So it's not like, it's going to look sort of like an umbilicus. And if you go back and tattoo it and give it shading and stuff, if you really want to go that far, you can do that and really make it look good. So, yeah, I mean, but in the end, there's no point operating if you're going to have them recur. I mean, you may as well not operate.
Well, let's point out though, the recurrence is about 5% overall, whoever you read. So it's not zero, regardless of how good we are.
I don't agree. I think that those 5% weren't thoroughly excised. I mean, sure, it's 5%, but that's 5% of the time that someone didn't take all the disease out.
Well, like cancer, I mean, we do a big operation, we get perfect margins, and the patient comes back, you know, a year or 2 years later with cancer, and we have all the pathological, you know, data. So, you know, I just have a hard time always blaming. No, but I always have a hard time blaming the other guy. I mean, you have to, you know, we get messes, of course, but you know, I just have more of an open mind to the fact that I don't want a recurrence, but you know, the fact is the fact. Whenever you have somebody say 100%, it's, you know, I just have a
well, yeah, it sounds crazy.
It's a grain of salt with that.
It's not. Listen, I mean, pelvic endometriosis, I would never say that. I mean, I think that we have recurrence rates for pelvic endometriosis. I don't care what any excision surgeon says about it's never going to come back if you remove it all. I don't believe that. But I don't know. I mean, I think abdominal endometriosis, if you get a good margin around it, I just haven't seen it ever recur. I do think people do surgeries that just don't seem to understand the depth of the disease. They just get too superficial or they don't go deep enough or whatever. I mean, maybe I'm wrong. That's my feeling.
Oh, Dr. Chung, you had wanted to share something on the screen. Do you still want to do that?
Well, it's just some gross picture of.
We love gross pictures.
I don't know where I can get to it, but let's see what happened here. Can you see that?
Yeah.
All right. Okay. So there's a whole bunch of it.
By the way, this is our trigger warning.
All right. So this patient, this patient is about 42, and she had hysterectomy, as abdominal hysterectomy, when one ovary was out. And then in the beginning, she said there was like a 2-centimeter mass, and she went to one gynecologist and she cut something else out, and it's endometriosis, and then did not follow through with it. And then by the time she came here, then she said, well, I get this mass, which happens that swell, she called, once a month. And that's the size of it. It's occupied the entire lower suprapubic, this is umbilicus. And the size of the mass here is more than 16 centimeter. And it's terrible. And it's involving the fascia, the muscles, and by the time it's all out, that we have to involve the plastic surgeon. The general surgeon didn't even want to fix the defect because it was huge. So I guess a lot of those issue is the gynecologist or the provider. Just like you have to know that there's abdominal wall endometriosis and suspect just like ectopic. You got to think about it. And these are one of those cases. It could be 2 centimeter without have to cut out the entire abdominal wall from that side to that side, completely clear margin. And the graft is almost like 20 centimeter. And he had to drill a hole in the pubic bone to be able to connect the fascia, the mesh. So anyway, I just wanted to share with you about this whole big lump. And
yeah, it's a big one.
It's
well,
huge.
it brings up the point that I have a huge experience with sarcomas. I've probably done over 500 sarcoma operations. The approach to endometriosis overall, it has to be a multidisciplinary approach from a technical standpoint of surgery, because we talk about abdominal wall, we talk about I call extragonadal disease. Again, I'm not a gynecologist. The incidence of endometriosis outside of what we'll call the gonads or the is a lot more than I think people still have to recognize. So it involves a lot of different specialties, I think, with a lot of different interests in order to treat these patients.
Very true. Well, I've been in Kent for 2 years. I already have 4 cases. Wow. And one of the cases, the abdominal endometrioma, was about 3 centimeter. But you want to make a clear margin that is much bigger. But after I finish up with it, you need a graft. So you always almost end up needing a graft. So we'll just put one of those mesh in and stitch it up. So that's the thing. I think that since I don't know too many general surgeons here now, if something that big, obviously they're gonna be in the room, because there's no way that I'm gonna mess with it just myself. Even take it out, it's a pretty long surgery just to take out the whole thing.
Awesome. Okay, so I think somebody said, are you at more risk having it improperly removed or just leaving it alone? Like if you're left with the choice of somebody will take a little bit of it out, or or leave it alone and do nothing and suffer, which of those 2 choices should you choose?
Neither.
Neither. Get it done right.
Right. So I mean, one of the reasons, like Dr. Wasson does a lot of teaching, and we are trying to spread the word. And this was amazing because we showed multiple techniques, but not everybody can access that. And I think we're working on, disseminating information everywhere so that people can begin to access it.
Sometimes the thing is the principles of removing it, I think, especially if you're going to do it with a laparotomy, I think the laparoscopic principles are very advanced. And Dr. Wasson's case she showed was great. You can't just like tell someone how to do that, but you can tell any general surgeon how to remove an abdominal endometriosis, even if they've never done before. The problem isn't that it's hard. The problem is that they don't understand the principles of what they're trying to do, which is to treat it like it's a sarcoma and remove margins, remove fascia, remove muscle, and get it all out. And any board certified general surgeons should be able to do that. And then once there's a hole, they either primarily close the fascia or put a mesh or whatever, and they should know how to do that too because they're general surgeons. So like I have people call me from other places with abdominal endometriomas, and often, sometimes they come to see me, but sometimes they can't or they don't, or I say, well, they're thinking about going to X surgeon, and I said, well, have the surgeon call me. If they haven't done those kinds of cases, have them call me because they will be able to translate a fairly simple set of instructions to doing a good surgery. Like it's just not that. I don't think it's like pelvic endometriosis where it's technically very hard to do some of these really advanced cases, and it takes a lot of years to become good at them. I don't think this should be too hard as long as someone understands what they're trying to accomplish, and that's where they fail.
And to your initial question, Sallie, leave it alone or take some of it out. I would say leave it alone because your symptoms are going to continue to be there. You're going to continue to have pain. So you're not going to solve the main issue of what you're trying to have surgery for. And then you're going to make it that much more challenging for the subsequent surgeries. So either do it right or don't do it at all.
Right. That's how I feel about it.
I mean, you could say the same about endometriomas in the pelvis. When people that don't know how to do endometriosis surgery, they go in and they see bilateral endometriomas. They say, well, I'll just try to do something. And they drain the endometriomas and take out a chunk of something. And it makes the surgery so much harder later.
Right.
It should
Dr.
just close.
Vidali and I had an entire conference on that in October on really how to manage that properly. So as we begin to wrap up, I want to talk a little bit about the Endometriosis Summit. Perhaps Dr. Wasson and Dr. Fogelson, if you want to, you could add those slides as recorded content as extra to the Endometriosis Summit. But the
I'll show some of those videos at the next thing.
Cool. So the Endometriosis Summit will be 3 days this year. We will have Endometriosis Summit surgery, Endo Summit workshop, and the Endometriosis Summit patient and practitioner town meeting, which of course is our bread and butter. We added Endometriosis Summit surgery. It's going to be much like this, but it'll be one doctor to one lecture, not a big panel like this. But we will include 2 hot seats where you're able to bring your cases to the panel itself. So Dr. Mawad and Dr. Mitroy will head a surgical panel, and then we will have a pelvic pain hot seat with Dr. Shirkandi, Dr. Tracy Scher, we hope maybe Maurice Chung, and also his team that published an amazing study. And we'll have hot seats the first day, and it'll be amazing. The second day will be about how to live life with endometriosis. We have a live art project on expressing yourself. We have something on ovulation as a measure of health and wellness. We have Michelle Lyons, who is an incredibly well-known physical therapist, coming to talk to us about great guts. And we have another interactive exercise project going on by Amanda Olson. And then, of course, our town meeting comes, and we will have everything from the history of endometriosis and how that impacts care, to informed consent, to thoracic endometriosis, to race and endometriosis, and of course, the Braverman Memorial Lecture, which will be laparoscopic sclerotherapy for endometriomas and fertility. So we're moving forward tonight at 9 p.m. Tickets are going to go on sale. It's a pre-sale ticket, so you can buy all 3 days on www.theendometriosissummit.com. This is not going to be your average conference on Zoom. The first day is geared mostly towards surgeons to have an open forum like this to discuss things. But that will be a hybrid option, half in Orlando or in your own living room, because that is what's safest for most of us. And there will also be a virtual option for patients worldwide. And we look forward to seeing everybody. Dr. Fogelson, before you leave, what are you looking forward to about the Endometriosis Summit?
Well, it's my first year of being involved, and I appreciate your invitation, Sallie. I mean, it's great to interact with patients and pass on some information about what I know. And you know, I've always enjoyed, you know, trying to be an educator. I used to be in academia like Dr. Wasson, and now I'm on my own. But I find that you can be just as academic when you're out of academics as you can be when you're in. And So it's going to be a cool experience, and it's fun to talk to all our colleagues, but also it's great to connect with patients, not patients, people that are interested in endometriosis. Some of them become patients one day. So it'll be great. Look forward to it.
Dr. Wasson, what are you looking forward to about the endometriosis? It's really hard for Andrea and I because we're used to the crowd. Like we're used to 700 people and the ruckus and the t-shirts and the whole thing. But now we have to pull that back a little. But we're excited to have everybody. Dr. Wasson, what are you looking forward to?
Yeah, similar to Dr. Fogelson, this is my first year, so I'm really looking forward to participating. And one of my biggest passions is really showing people how to be advocates for themselves. And so just the opportunity to not only reach women who are suffering from endometriosis, but family members, allies, not just the healthcare providers. I'm really looking forward to the wide audience that's going to be at this meeting.
Right, you found the right forum if that's what you're passionate about. Now, for everybody that wants to know why the Endometriosis Summit is so multidisciplinary and why we spend so much time not only talking about endometriosis, but about multiple generators of pain, from groin pain to interstitial cystitis to everything else, it's because I know this guy right here, Dr. Chung. Dr. Chung, what are you looking forward to most about the Endometriosis Summit?
It's exciting. I just want to be there and share my passion so everybody can hear, and hopefully I can help a lot more patients and women.
Yeah, we're excited. And Dr. Raccuia, you're with us for your third year. What are you looking forward to?
Well, I mean, my interests are the extragonadal diseases. I think that it's much bigger than people have thought about in terms of treating endometriosis. And, I think, they think about the endometrioma. They forget the rectum, they forget the ureter, the bladder, all these other areas that traditionally are not areas of a gynecologist training. So like sarcoma surgery, like liver surgery, endometriosis surgery needs a captain of the ship like Dr. Vidali to be able to say, we need to do this, we need to do that. We expand our surgical techniques through understanding that this disease is not really a gynecologic disease. I'm going to tell you, it's not.
Yeah. So we'll give a little shout out in the comments has been Wendy Bingham. And if you want to learn a lot about extrapelvic endometriosis, you can check out her website, Extra Pelvic Not Rare. Dr. Vidali, we're about to get the show on the road with the Endometriosis Summit.
So excited.
What are you most excited to see?
Look, what I'm excited, like every time we organize this, we end up interacting with such amazing people. I had never, I had never interacted, at this level, neither with Dr. Chung or with Dr. Wasson. I know Nicholas for a long time, but it's amazing. I find it very exciting that we are offering this forum where, we're giving a voice to patients, but also we're giving an opportunity to doctors to, in a collegial way, express themselves. And I think it's different from like AAGL or something. It's a different feel, right? I think that's what I'm looking forward to.
There is no book that tells you how to treat endometriosis. It's like, I learned this because I was interested in it. I got mentorship in how to operate. Like I learned cancer surgery, and then I taught myself how to treat endometriosis. No one taught me. And so I think that a lot of people are in that boat where you get good at surgery, and then you become interested in the field and you start interacting with general surgeons and urologists and colorectal surgeons, and over time. And so, I mean, it's surprising how differently some people think about the disease state. And it is not, there are some people out there that would like to say that we have it all under a button, like we know exactly what endometriosis is and exactly how to treat it. But I don't believe that's true. Like, I think that it's a huge, mysterious condition that we know very little about. And any amount of cross-pollination of ideas and being very open to lots of different ideas, because no one thing is true for every patient. I strongly believe that the disease is very multifactorial, very multigenetic, and certain things are going to work great for some people and not good for others. And so being able to collaborate in mind with other surgeons and patients is so important.
Right. So ticket sales are now open for that pre-sale ticket, which is our 3-day ticket. And we will be back at you with a different panel next week on painful sex. because it's always awesome to talk about sex with my parents in the next room. And I can't wait to see everybody. And I hope our 4th Endo Summit, which is not this year's, but next year's, we will all be together in person, healthy
Oh,
and
yes.
safe.
So we can have a good party, right, Sally?
Yeah, you know, I
We need
had
one.
planned disco bowling
Who-
for our
Who's been
faculty.
immunized? Who's had their COVID vaccine?
Me?
Yeah.
But we have.
I got mine. Wasson, Megan, you haven't had it yet?
No, I've got it. It's
Oh.
in.
All right, we can all get together then.
You can't get them in Florida. All right, take care, everybody. We'll see you soon.
Thank
Good
you.
Okay.
night. Thank you.
Thanks, mate.
Bye-bye.
Bye.